Hello, everyone. My name is Samir Parekh. I'm a hematologist at the Mayo Clinic in Rochester, Minnesota. I am delighted to welcome Dr. Brian Koffman today to discuss an abstract that he and his team have presented at the 2021 annual ASH meeting. Dr. Koffman, would you like to please introduce yourself?
I'm Dr. Brian Koffman. I'm the Chief Medical Officer, Executive Vice President, and co-founder of the CLL Society. And thank you very much, Samir, for being interested in our research.
Thank you. So the abstract that we are actually discussing today is titled Awareness, Knowledge, and Preferences of US Patients with CLL and Their Caregivers as it relates to finite duration of therapy, as well as what is also now coming into vogue called as minimal or measurable residual disease. And I think this is a topic that is of particular interest to all of us as clinicians who care for patients with CLL, because things have evolved in the management of CLL. Over the years, patients initially would get chemoimmunotherapy, which was fixed duration therapy like FCR or bendamustine-based treatment. And then it sort of changed over time to more continuous therapies, such as ibrutinib or acalabrutinib that patients would take until there was disease progression. And then now, we are in an era where fixed duration therapy with these novel oral molecules is happening again, where, patients take a combination of treatments, which are oral pills that are also fixed duration now, and that are able to induce deep remissions. And so I think I'm really interested to learn what you found with the research, Dr. Koffman, that you did with your study with respect to patient and caregiver preferences.
Well, thanks for that. We wanted to understand what the patient's, self-assessed awareness and understanding and preferences were related to finite therapy, MRD, minimal or measurable residual disease in the present treatment era, knowing that this pendulum has shifted, as you so well described. And we wanted to look if there was any gaps or misconceptions in their awareness and understanding that could be addressed in that patient education and shared decision-making. So we set up a survey, and really the admission criteria to get into the survey were pretty simple. You had to have CLL or SLL, and you had to have a working knowledge of English and be over 18. We had a good response, 630, of which 608 were patients, the rest were caregivers. The survey ran from the end of 2020 to the beginning of 2021. The average age, like in a lot of surveys, tended to be younger than the average age of CLL patients. It was 64, and there were more females. Females always seem to fill out surveys more than men. We had respondents from every single state in the US. What was interesting is the majority of patients had been treated with a novel agent for their CLL. Patients were quite aware of what their prognostic markers were, so it was a sophisticated group. The most don't knows was for TP53. The other FISH studies, they actually seem to have a better knowledge of, but 38% didn't know their TP53 status. Much fewer percent didn't know their 17p status. So that is one area that we may want to look at. We asked patients how familiar they were with MRD. In the vast majority of them, some 89% of patients felt very familiar or somewhat familiar with MRD. And a majority felt confident in understanding its role and confident of when it should be, what it measures. But having said that, there was clearly a knowledge gap because a significant number of patients would want MRD testing during or after treatment when labs showed persistent CLL. So if we know if a routine lab shows that you have CLL, there's no point in doing MRD testing. Even a small percentage of patients wanted it at the time of diagnosis, but if you're diagnosed with CLL, clearly you have measurable disease. It's not residual disease, you have measurable disease. So there's a learning gap in terms of understanding what MRD is and when it should be used. we asked patients to look at limited or fixed duration in terms of how important that was in their decision about how they should be treated. And what was interesting here and surprising, and I'm very upbeat about this, is that half the patients, when they were forced to rank what was most important to them, ranked overall survival is the most important thing, followed, that was half the patients, followed by 30% saying no chemotherapy. And issues like limited duration or MRD were much lower. Now, the reasons people chose limited duration therapy was it was a chance for a continued remission while off treatment. Patients want to have that long glide path. And 93% of people rank that, or 92% is something very important to them. A significant number of patients wanted a period of time without side effects, and that was also extremely important about why they did choose limited duration. So in conclusion, overall survival and avoiding chemo and preserving future options were the important treatment factors when people had to choose a therapy. Ability to reach MRD was rated more important than the duration of therapy. Patients expressed significant self-confidence in understanding MRD, but 18% of patients still wanted testing when in their peripheral blood when labs showed persistent CLL, suggesting that there's a knowledge gap here that we might be able to help. Regarding understanding of which treatments like BCL2, BTKI, chemoimmunotherapies can achieve undetectable measurable residual disease, a full third of patients were unsure. There were some problems with the study. It was opt-in. 1 out of 5 patients came from California. So the results may not be reflective of all patients and caregivers because these would be motivated patients who took the survey. So what do I take away from this? As the importance of MRD and finite therapy grows in CLL management, it's going to be incumbent upon the providers to better understand and consider their patients' awareness, understanding, and preferences, and to help patients become more informed about these evolving practice choices so they can make better decisions. I hope that helps you in your work as a clinician and other clinicians better understand their patients.
Yeah, no, this is hugely important, right? I mean, as I was hearing you describe the results, the thought that crossed my mind was, patients know best, right? I mean, I think overall survival and how long am I going to live is the #1 criterion that trumps everything else. MRD, no MRD, limited duration, no limited duration. I think if you can give me treatments that I can tolerate, that is going to make me live longer, it doesn't matter, right? Because that is the ultimate sort of yardstick against which everything is measured. I think increasingly we are looking at trials where they are going to be looking, for example, the CLL 17 study, which is being done by the German CLL study group, that's going to be comparing continuous ibrutinib therapy to fixed duration therapy with venetoclax and Gazyva and venetoclax and ibrutinib as 3-arm study. And one of the arms is actually continuous ibrutinib based therapy. And if overall survival really is the most important outcome, as our patients tell us, and if continuous therapy, makes people live longer compared to finite duration therapy, only time will tell once the results are out. That might change our perception of, the pendulum may swing back again to continuous duration therapy. So I think, it's important to keep patient perspective at the front and center of everything that we do in our clinic and the trials that are designed. So thank you very much for, this very insightful work. I appreciate you taking the time to share these results with us.
Thank you, and thanks for your interest in this.
Thank you.